We have a visiting professor that will be sharing a talk today, but I will invite the person that invited the visiting professor to come and introduce him for this talk. So, Dr. Malayani.
Thanks, absolutely. Technically, it was actually a former student of the University of Calgary, Trevor Day, who invited Dr. Dempsey. I just kind of poached him for this at the same time. So I'll keep this brief. I'll give the obligatory things. Jerry's published over 420 manuscripts, 44,000 citations. His lab was funded for 50 years continuously in the NIH. He's won every award for every conference, everything that I can possibly imagine is too long to list. Jerry's an expert in both the field of cardiopulmonary physiology and exercise, which he's going to talk about today, but equally a giant in the field of sleep apnea. We spent actually yesterday down at the hospital talking a lot about that. What I want to spend a few seconds on, though, is I think what Jerry's probably most proud of is his trainees. So Jerry has 68 pre and postdoctoral trainees, and so I did a little bit of family treeing, and by my count, Jerry's trainees have trainees who have trainees who have trainees who have trainees. I'm probably missing some of the earlier ones, but
I'm not that old. I don't.
That's
Never mind.
a testament to how far the reach of Jerry's trainees are and his things. So I actually met Jerry in 2011 at ACSM in Denver. And really just to show how generous Jerry is with his trainees, I was sent there by my supervisor to show Jerry data. And after showing him data, he insisted that I came to dinner with him and a bunch of the other Rankin lab. So that was a little intimidating for people that I've just read all their papers, and then all of a sudden I'm sitting there having dinner with all of them. But he's always been so generous with his time and energy to always talk to trainees and to talk to my trainees, and just always sharing his love for physiology. And as another tidbit, I learned this yesterday. His trainee is a former dean of the University of Calgary kinesiology here. Roger Jackson was one of Jerry's trainees back in the day. So his reach goes very far.
Thank you, Carl.
Okay.
Okay, forward for the kind of sign. Thank you for those generous words. Following the good memories. Good afternoon, everybody. So nice to see all you Canadians. He didn't tell you that. I'm a Canadian. I'm from London, Ontario. Raised there. And I'm extremely proud of that. And I'd like to say of those wonderful bunch of trainees that not just me, but our whole group at the Rankin Laboratory had over the years, we had 14 Canadian. We won a lot of intramural hockey championships. Okay. So, and Edmonton as well. I was a year and a half in Edmonton. So Western Edmonton, Wisconsin, and now where we are in Calgary. It's been a really super week. The hosts have just treated me royally. Met some wonderful people. We've shared a lot of stuff and thoroughly enjoying myself. Where's Trevor? There he is. Many thanks. Such a good host. This is where I'm from at the current time. Madison, Wisconsin. I've been there a long time. It's the capital of the state, the home of the University of Wisconsin, large land grant institution, the 1848 founded. This is one of the lakes. Madison's on an isthmus surrounded by 4 lakes. The campus is borders this larger lake, Lake Mendota. They're only have indigenous names. This is our founder and my supervisor, John Rankin, a Scottish pulmonary physician, moved to Wisconsin in the 50s, and was just a wonderful man and a super boss and a great mentor. And when he passed away at way too young an age, we named the lab after him. And I'm always grateful for his mentorship. Here's what I want to talk to you today about. This is a culmination of a bunch of stuff we've done. And it's about neural feedback controlling cardiorespiratory response to exercise and performance. We'll talk mainly about health, but also bring up some pathophysiology as well. here are 3 Canadians here that are doing pretty well today, and they were postdocs in the lab, seems like a long time ago now, very important to this work. So neural feedback mechanism regulating exercise physiology and performance. The responses I want to talk about are these: respiratory, cardiovascular, and then these aspects of performance. And what I'd like to try and convince you of is that these specific neural feedback mechanisms play a role in regulating these functions during exercise. They're not the only thing by far. And we think we know a fair bit about them, but there's a lot of unknowns as well. So when we usually think of this kind of neural control, this response, what gets most of the ink or dominant roles for feed forward, central command type mechanisms that regulate parallel pathways that regulate both locomotion and cardiorespiratory responses. A lot of more recently learned mechanisms that are so-called learned also dominate these. That's not what I want to talk to you about. I want to emphasize on these neural feedback mechanisms, 4 of them. Muscle afferents, locomotor muscle afferents, respiratory muscle afferents, a little bit on feedback from the lung, and the chronic chemoreceptor. We think there's evidence supports them as key obligatory mechanisms in the response to exercise. So we know if you stimulate the receptors in these different organs, they will produce exercise-like responses. But that doesn't tell you whether they're obligatory to the exercise response. We feel the way to do that is that to test for that is in a setting of physiologic exercise, that is a human or an animal exercising, reversibly block the mechanism that you're questioning and see whether it has an effect. That's the way I think you can tell whether it's obligatory to it. So that's the approach that I'm going to present to you today. So here's an example of some of the key cardiorespiratory responses to exercise. The one I think the most about is breathing. And this is well established. Some of the things says CO2 production and oxygen consumption increase in the steady state. Here's the ventilatory response. Well, tidal volume, the pretty precise regulation of arterial gases, especially in moderate exercise. Lung gases, rising linear cardiac output, control of blood pressure, and vascular conductance. Those are the kinds of things I want to talk about. Okay. So let's start with our first locomotor muscle afferents. This is what we found out the most about in the last few years in our lab anyway. Group 3, mechanosensitive muscle afferents, and group 4, metaloreceptive. And they interact with one another. How are they activated? Either with muscle contraction, deformation of the muscle, or through muscle metabolites, or even with distension of the veins in muscle through blood flow changes. So lots of things activate these. They're activated. We used to think it was just an isometric contraction that activates. That's not true. Even very slight rhythmic contractions will activate these muscles or these receptors. They synapse in the dorsal horn of the spinal column, but they also have several. It seems like we're finding more of these all the time. Central projections to the nucleus of solitary tract, the medulla, retrotrapezoid nucleus, which is the central chemoreceptor, hypothalamus, and even to the cortex. So, peripheral neural feedback, but lots of central projections. So our question is, are these afferents obligatory to the cardioventilatory response to exercise? That's our first question. So how do we address that? Well, you have to stop, you have to block them while during exercise. The usual way to do this was to give epidural lidocaine. And this was done in a whole series of studies, especially in Denmark for a long time. The problem with that is it just doesn't block afferents, it also blocks efferents. So it makes the muscle weaker. So it ruins your model of just looking at the effect of afferents because there has to be a compensation for that muscle weakening. So we had done that in a study, Marcus Salmon, that was postdoc at the time. And he and I had done this epidural lidocaine block, saw a lot of responses that we weren't looking for. And then through our cooperation with our clinical colleague, Les Proctor, an anesthesiologist, he said, guys, why don't you try fentanyl to block muscle afferents? Really? Yeah, he said, and from what I know, it doesn't do anything with the efferents. Now, this guy never done an experiment himself. He done medical school, terrific clinical anesthesiologist, but he read the literature and he talks to people and he was right. We tested it all. It did nothing with the efferents that happens, but it sure does the job. Well, of course, we know this is if you keep it intrathecally, if you keep it in the spinal cord. We all know from reading the news every day, don't we? If it gets outside of that, it's not fun. Brainstem's very depressed with this. And so that was our goal. And Mark Kaufman and his student Janine Hill had shown very nicely in anesthetized cats that the new opiate receptor agonists blocked the response. It was blood pressure response to induce muscle contraction in this size cat. So it looked like a good bet to use this new opiate receptor agonist. And was, as I just said, only the afferents are blocked. And it's about a little under 50%, we estimate, is the block. We can't get a full block, not with the dose we use now to keep it intrathecally. Okay. And we did several tests. I could talk about these later, that's published, and to test to make sure that it was contained within the spinal compartment, did not reach the brain or the systemic circulation. Okay, so that's our model. And this is infused at just the right dose, and the person exercises, and this is an example of the kind of response that we see. And we do a placebo too with saline in the intrathecal space. So here's rest, mild, moderate, heavier, maximum exercise in healthy cyclists. And here's the mean arterial pressure response. Nothing happens at rest. Nothing at rest with this, thank goodness. We haven't affected the rest. That means it's doing more than blocking muscle afferents. We don't want that. Okay. But at each exercise load, you can see the effect on blood pressure. Here's the response with saline, SIBO. And you can see that at the moderate exercises, we blocked almost all the blood pressure response. In heavy exercise, we blocked about half of it. And even with this lower blood pressure, there was still a fall in heart rate. So even though the baroreceptors are obviously feeding back to bring the heart rate back up, there was still a relative bradycardia. So we see a persistent reduction in heart rate, blood pressure, some evidence of sympathetic nerve activity, indirect ones, limb vascular conductance, and small changes in cardiac output. Okay, big changes in limb vascular conductance. So there are these cardiovascular effects of the muscle afferents. What about breathing? Because this is the one, and this, we weren't looking for this at all, but this just happened. So same protocol. Here's breathing frequency. Again, nothing at rest. Even at the mildest of exercise, and even in the first few seconds of exercise, you start to see a reduction in breathing frequency. And it stays that way pretty well up to the maximum exercise, not as much. And you can see that means ventilation, and any given CO2 reduction is reduced. That means you retain carbon dioxide in your arterial blood. Then, because of a lot of pushback, this topic is highly controversial. People have been looking for the mechanism for exercise hypertrophy for a century. This doesn't solve it, this is the first evidence that these afferents are obligatory. So we get a lot of pushback on this. People thought, oh, your exercise loads are much too brief. You're not reaching a steady state. So last year and a half, Marcus Thomas in Utah, and he did 20-minute periods of exercise rather than same thing. Also, if we do a 5K time trial on a cycle, this is what that, here's time trial. So here's power output, and here's distance on a cycle, okay? And here's the control, and here's the placebo. And you can see when you block the afferents, you get quite a different response of the cyclist to the cycling, don't you? Look at the beginning here, great overshoot. Do you think he needed that feedback to tell where he was, or where he wanted to be? I think so, but I'll leave that for a sec. We're talking about breathing here. And I'll talk about that too. So what was the breathing response in a non-steady state type? Same thing as we saw in the steady state. Ventilation suppressed, retained CO2 throughout. So from these kinds of experiments, we think we can postulate that group 3-4 muscle elements are required for exercise-induced sympathetic excitation, blood pressure, breathing frequency, hyperpnea. This is only in an animal model. I'm going to show you now. We're just looking for this in the human, so we're not sure in the human, but it's also important for that. So this is important. You block it, you have this effect. There's a few caveats here. The amount of muscle mass involved is going to make a big difference. Whether you do with a small muscle mass, you won't get nearly the effect you will with a large muscle mass. You're going to engage more receptors. We thought we'd have to work really hard to see this effect, but we saw even at very mild exercise, there was hypoventilation, reduction of blood pressure. So rhythmic exercise brings these receptors in. The limitations to these studies is this is only a partial blockade we're dependent on. So we can't possibly say what relative contribution to these makes to say to the total hypertrophic response, the total sympathetic response, because we've only blocked part of them. And of course, this is certainly not the only stimulus that's affecting exercise improvement. There are lots of other ones, including central command, but I'm not going to go into that. That's not my purpose today. Our purpose is to focus on the obligatory effects of this feedback, but there are lots of unknowns here. Happy to talk to you for several days about those of you that you are interested. And now in the last few years, 3-4 years, this same experiment has been tried in heart failure, in hypertensive patients, and COPD patients. And in every case, even in extremely mild exercise, there's a much larger muscle afferent contribution, breathing, the blood pressure, the sympathetic nerve activity, the blood to vascular conductance than we saw in health. So it's expanded into the clinical realm. These are important. Okay, next topic. So these muscle afferents seem to have an effect on cardiorespiratory regulation, but we think shows that this is obligatory. They're just not redundant mechanisms that can come in. They're required. What effect do they have on performance? So actually, that was the whole purpose of this to begin with. How the heart and the vascular system breathing response was not what we were looking for. We were looking for performance, and that was Marcus Hammond's primary focus here. So based on some descriptive data that we had with giving cyclists hyperoxia, hypoxia, and normoxic environments, and again, putting them on a time trial, we find, for example, that the hypoxia, they were slower, okay, and the power output was less. They were hyperoxic, they were faster in the time trial, and the power output was higher. But when we tested their fatigue at the end of it, by supermaximally stimulating the phrenic nerve and measuring the force output, the fatigue was identical at the end of every one of them, regardless of the speed of the performance or the mean power output. It kind of said to us that something's trying to keep that amount of fatigue we develop below a critical level. And this had been postulated decades ago that maybe there are mechanisms that kind of protect. Well, we think the mechanism might be feedback from the muscle. Okay. So how can we test for that? Do the time trial performance and do the muscle afferent block. And we saw, and I'll repeat this now, the effects on pacing and power output, the effect on, now we want to look at the effect on fatigue and performance. But the way we're doing it was a problem. This is the data I just showed you a couple of slides ago. So this was the usual, highly reproducible in these cyclists. Time power output during their time trial performance, the sprint at the end included. But when they had the fentanyl block, they greatly overshot at the beginning. And of course, you can't maintain that pace. And I don't show these here, but lactic acid levels became extremely high a couple of minutes in, and fatigue developed quickly. But you can't look at the effect of just the block on performance, because you had all these confounding effects like hypoxemia, CO2 retention. These are going to affect oxygen transfer to the muscle. And so they're being effect independent of just the afferent feedback. So how can we get around that? So our thinking was, we want to preserve oxygen transport. And we measured blood flow and gave extra oxygen to prevent this kind of an effect during the trial. So here's what we found. Okay, and now we're in hyperoxia. And what at the bottom line, I'm going to show you the data. It ended up with the afferent block, higher sustained power output, faster performance, more muscle fatigue at the end. In other words, these afferents are constraining the amount of fatigue that was low. Let me show you. So here's the power output. So here's normoxia. There. Okay. Here's the hyperoxic effect. You can see the power output a little higher. This is again with no block, this hyperoxia. Then here's the combination of hyperoxia with fentanyl. So now we're preventing the hypoxemia that accompanies that under ventilation. And you can see how much higher the power output stayed. Still got the overshoot. The power output stayed high. What else did we find? We found the time of performance was substantially faster. Even faster than you can get with hyperoxia. That was impressive. I forgot what it was, something like 4 to 6% faster on the time trial. That's pretty significant for athletes. And then we also found that the amount of fatigue at the end was increased to about 38%. So we'd like to conclude from this. Muscle afferent feedback influences the ventilatory response, the vasculature. It affects early pacing decisions in a competitive event. You greatly overshoot without that feedback. Constrains central motor, neural, and power output, and limits muscle fatigue and performance. So take this together. Cardiovascular response, the respiratory response, and the performance response, we think is paradoxical. Muscle afferent feedback ensures adequate performance. You ventilate enough. You keep the oxygen high enough, while inhibiting central motor output in order to constrain muscle fatigue below a so-called critical level. So I think these muscle afferents are important in an exercising human. Okay. Let's go on to another receptor. Any comments or questions on the muscle afferents? You're not gonna tell me are you trying to tell us, sir, that these muscle afferents, the only thing that determines performance? Of course we're not, right? Yeah,
Would you expect that a similar response would be seen in those with spinal cord injuries?
in those what?
With spinal cord injuries, depending on where you would,
Oh, I have no idea. What do you think?
wish I knew. I had to refresh myself on afferent knee, for instance, we started talking.
Well, I mean, the motor system's not gonna be intact, but I guess the afferents would be intact. So yes, I would.
In some, I guess it would depend whether it's complete or incomplete.
Yeah, where the region is, and, yeah, good question. Okay. Now, here's another kind of afferent. This is my favorite one, actually, because it comes from the diaphragm. Here's a couple of Canadians, all of this. Okay. So the same kind of group 3, 4 afferents that are in locomotor muscles are really highly dense in the diaphragm. In fact, we think of the phrenic nerve as a motor nerve, but almost 50% fiber than the diaphragm are afferent. So they've got to be doing something. The same kind of properties, especially these free nerve endings, unmyelinated and lightly myelinated, even more so in the diaphragm than in most locomotor muscles. So they're heavily dense there. What do? They're activated. You fatigue the diaphragms from joint, you can buy direct recordings from them. It activates them. Beautiful series of studies at McGill. It's what got me interested in this field in the 80s, in the anesthetized rat. You infuse capsaicin to stimulate from the diaphragm. You see breathing change, you see heart rate, cardiac output, vascular conductance change, just as if they were locomotor muscle effort. We know now some of them, not a whole lot of work, but they're central projections, just like locomotor muscle effort. What's their role during exercise? Well, we tested this in the canine model and in a human over a bunch of periods of time. Canadian. Oh, look at this. I think he's sitting over there. He wasn't in my lab when he did this. In fact, he took you guys long enough to test this. Okay. So let's see what happens. So we started off with an animal model to test this. The reason I use an animal model is because I want to have a way to block the sympathetics. And you can't really do that as much as you'd like to in a human, but you can in the animal. So and plus the way you can measure stuff, we put blood flow probes that measure beat by beat blood flow on the hind limb muscle, abdominal muscle, renal. So we knew about blood flow distribution. We did moderate intensity treadmill exercise. Dogs love to exercise on the treadmill. And we activated the diaphragm metabol receptors by infusing lactic acid into the diaphragm through the phrenic artery. Was this a physiologic insult to the diaphragm or acidification? I have no idea. We weren't trying to mimic what might happen during exercise or anything. We just wanted to activate these receptors. And we looked before and after sympathetic blockade. And here's what we found. So this is not just all this data, it's published long ago. Percent change from before injecting the lactate. Blood pressure, well, just like you'd expect if you activate the locomotor muscle. Cardiac output, small reduction in cardiac output. Blood flow to the limb went down. Lots of vasoconstriction in the limb. We think in vascular conductance went down. So obviously sympathetics, vasoconstrictors had to be activated. And if we blocked the sympathetics with phentolamine, this blocked all these responses. So this was proof of principle evidence that these muscle afferents in a physiologic preparation during exercise had these cardiovascular effects. Well, how do you get at this in an exercising human? We haven't come up with a way, even in a rat, of blocking these efforts like we can do with the motor muscle efforts with intrathecal fat. Doesn't do it. So this is what we decide to do. We manipulate how hard the respiratory muscles will work. That was the approach that we took. We had a very special ventilator invented by a portfolio of scientists in Winnipeg by the name of Maggie Eunice. And it can breathe for you, even an athlete at maximum exercise, once you get used to it. In fact, it's a wonderful feeling. And I was the first one I'm not a endurance athlete, I'm an old guy. Well, this is a long time ago. But I'll never forget the day we did it. And I got used to using the ventilator. I was sitting in a chair. I was on the bicycle, got a semi-heavy load for me. I was starting to feel fatigue. And the first several breaths I got on that ventilator, the first thing I felt was relief of my limb fatigue. So something must have been going on, maybe with my distribution of blood flow. That's what I want to talk to you about. So here's what we did. This is typical of esophageal pressure change, inspiration, expiration, and heavy exercise. And this is the pressure developed by the diaphragm. You put a balloon in the lower esophagus, one in the stomach, and you measure the pressure developed across the diaphragm, which is force. So you can see it's nice, big. Normally at rest, it would be about a centimeter or whatever. Okay. But we did that. And then we loaded the diaphragm with a resistor on the inspired side. Much more pressure generated here, diaphragm generating much more pressure. But that's not the important one. The important was unloading. So like using an afferent blockade using a blockade for muscle afferents to show whether it's obligatory. We wanted to reduce what might be coming up the phrenic nerve to see what effect it had. And to do that, we put the people on the ventilator. You can see the diaphragm working much less during this. All the respiratory muscles working less. So what did it do? It prevented diaphragm fatigue during heavy sustained exercise. We measured blood flow to the limb with thermal dilution technique, very invasive study. And when we lowered the part of breathing, increased blood flow. It had a small change in cardiac output. It reduced limb muscle fatigue and lengthened performance. Let me show you some of this. Long ago. Okay, this Craig Harms has worked with us. So here's bunches all put together, data in a dozen subjects. Here's the control here, limb vascular resistance, and blood flow to the limbs. Under control conditions, if we loaded the diaphragm and the respiratory muscles, we increase resistance and decrease flow. If we unloaded the diaphragm, we increase blood flow and decrease resistance. Remember, we think we're using this as a surrogate for decreasing or increasing phrenic nerve activity. So, in summary, we decreased the work of breathing, we prevented fatigue, we decreased indirect measurements here with sympathetic nerve activity, decreased limb vascular resistance, increased blood flow, decreased fatigue, increased performance. And Bill Shield and Paul Dominelli, many years later, did a very similar study, only they even went one further and measured blood flow to a accessory muscle, supracleidomastoid muscle here in the neck that you can get at, measure the flow with a dye technique, and found that when they unloaded the muscles, not only did blood flow increase to the leg, but it decreased to the respiratory muscle, which you'd expect. So I think this series of data confirm this effect of what we think are okay. What is unknown here is there, when we change sympathetic nerve activity, does this affect diaphragm blood flow more than it does locomotor muscles? We would think it might, but we don't know that for sure. And there's very little data to test that. So this is what we think this model is. Afferents from the respiratory muscles, feet up here, and affect sympathetic nerve activity. And this has perhaps a more preferential effect on constricting the limb than it does the diaphragm. Although this will be subjective to vasoconstriction at very high levels of sympathetic activity, so we don't know that for sure. The limitations in this is we presume that when we unload the respiratory muscles, we're decreasing the accumulation of metabolites. I think that's a pretty good assumption. But we don't know whether this decreases phrenic nerve activity. That's our presumption. Gonna have to find a way, and I know people in Milwaukee are working on a block for this in the road. That's what we need. So finally, my final feedback receptor is the carotid chemoreceptor. It's the smallest one, but I think pretty potent. We never thought it played much role in exercise. And we're still debating, almost doing some very nice studies and frustrating results on trying to show that these chemoreceptors play a role in the control of breathing during exercise. I'm not going to talk about that. I can't figure that out. I want to talk about its cardiovascular effects and its effects on sympathetic nerve activity and vascular conductance. And Mike Stickland, who's a postdoc, did a terrific job on this. This is Barbara Morgan, and the three of us worked together where Mike was in that. And Mike has continued a lot of this work in Edmonton. I'm going to talk a little bit about that as well. So, again, we looked at a canine model because you can walk the synthetics again, and humans. And more recently, with some pathophysiology, we're going to emphasize the healthy human over a long period of time. Okay, so I think a lot of you know about recording muscle synthetic nerve activity. All right, this is an example of that you give us a window in a human on muscle synthetic nerve activity. Of course, you have to stay real still. So recorded in the arm, which you can exercise the legs. So it's a powerful technique to look at this. So let's see what effect the carotid body had on this. Well, how do we know that? Well, you can transiently inhibit the carotid body with hyperoxia. Okay, it's the primary oxygen sensor, not the only one, the primary oxygen sensor in the body. So here's PO2, airflow, muscle synthetic nerve activity. And this can be from this is from a hypertensive human. We won't see this in normal human at rest, but it's also for what we saw during mild exercise, which I'll talk about. So you give this transient hyperoxia for even less than a minute. And as it rises, you can see ventilation fall. And if you look hard enough, you can see the frequency of the MSNA spikes transiently fall in this period of time here. So it's an effective way of reducing at least most of the activity coming up from the carotid sinus nerves. So we applied this during exercise in healthy people. Mike and Barbara did. And we kept ventilation constant. Tell you why that is, but we all had, it was mild hand grip exercise, so we could record the synthetic nerve activity, and we kept it constant. And you can see here's a change in MSNA from baseline. And we gave the hyperoxia here. And you can see this inhibition during exercise. And we didn't see that at rest. You had to do this mild exercise. Later, with both hyperoxia, and this is the major inhibitor transmitter for the carotid body, dopamine. Mike used both in humans, saw increase in lymphovascular conductance during exercise and blood flow. This was a few years later. Okay. So there are cardiovascular effects of tonic activity coming from the carotid body. This is under normal oxygen conditions in a healthy human. Now here's the canine. And the way we did it here was to have the injectant probe right up under the carotid body. So we could inject either hyperoxysaline or dopamine and get a very fast inhibition of the carotid body, and then measure all these things. Blood flow to several vascular beds. And this is what we found. So if you did this at rest in the canine, and I put up here is a healthy canine with an ejection fraction of over 50%. So it's a healthy canine with a healthy heart. And this is the change in limb vascular conductance. If you do a sympathetic blockade of rest, or tonic sympathetic activity, you get an increase in vascular conductance. But the carotid bodies did nothing. We inhibit them, they had no effect. But during mild exercise or sympathetic activities, 2.5-fold increased, then the carotid bodies had about accounted for almost 30% of that innervation of sympathetic activity. In heart failure, you can take the animal and pace them at a very high rate for several weeks and produce a heart failure model. And in this case, the ejection fraction is now extremely low, so it's a failing heart. And we also saw that the hypoxic ventilatory response was greatly increased. So the carotid bodies are greatly, and that's in a human too, greatly sensitized in heart failure. And what do we see here? Well, even if you block this at rest, here's the total sympathetic blockade, but the chemoreceptors are very important in regulating vascular tone. And during exercise, of course, it's very high as well. So heart failure, in the normal person, we only saw this effect of the carotid chemoreceptors during mild exercise. Now, this has been expanded to the pathophysiology, and people are seeing a high tonic activity in heart failure humans, hypertensive patients. Yeah, in the last 5 years, a lot of evidence now showing the pathophysiologic consequences. Okay, so both in animal models and in humans, especially heart failure is an interesting one, because the heart failure patients are not hypoxemic. If you're at high altitude, the low PO2 over time is going to hypersensitize your carotid chemoreceptors. But in heart failure, their PO2s are normal, but the blood flow is low. And there was some beautiful studies out of Nebraska showing that decreased shear stress at the carotid sinus level can enhance chemosensitivity. And that's probably what's happening in the heart failure patient. And then this high carotid chemoreceptor activity in the heart failure patient leads to all kinds of things. High levels of sympathetic activity, sleep disorder breathing, causes periodic breathing, excessive exercise tachypnea, high breathing frequency and exercise. This is a major question. If this pathophysiologically, if this carotid chemoreceptor activity is so high in these people, and the evidence is pretty good now, not just animal models, but human patients, how do you treat it? How would you treat that? What do you think? You've got reflex receptors that are tonically very high. They're causing renal vascular constriction, hypertension. How to do something about it? What would you do? If you can do anything you want. I don't care what receptor it is. If you could get at it, what would you do to it? Block it. Get rid of it. And there's one clinical study done on that in Poland. So, because this has an emergency function too, doesn't it? It's our major oxygen sensor. If you're sleeping and you get apnea, you need to wake up. You need to increase that tonic activity of the brain. You need oxygen sensors. So now people are looking all over the place, try and find a way to block the high tonic activity coming out of the carotid body, while at the same time conserving the emergency function of the carotid body to respond to asphyxia in the short term. In fact, Richard Wilson here is working on this now at the University of Calgary. So interesting stuff. So what I've tried to tell you, good for me, is obligatory neurofeedback mechanisms during exercise. affecting oxygen transport as the base homeostasis, synthetic blood flow distribution comes from these receptors. This one I didn't talk about, happy fruit. We don't know the relative contributions these make, but we do know they're significant and obligatory. And especially with muscle afferents, have an effect on performance. And now this has gone beyond the healthy stage, and we're seeing pathophysiologic excessive muscle afferent chronic chemoreceptor contributions to CSF hypertension, and the same with the muscle afferents. These fentanyl studies have now been done in heart failure, COPD, and hypertensive patients, even in very mild exercise. And the effects on the cardiovascular response are substantial, especially on blood pressure. So it's has both pathophysiology. Thank you.
That the floor is open for questions. Who would like to start us off?
Yeah.
In the intrathecal fentanyl studies, so you can push to more fatigue with fentanyl.
Yeah.
What do you think that means for the body's regulation of fatigue, or nothing bad happens when they get that fatigue? Like they're
Oh,
able to walk.
oh, let me tell you. Can I tell you
Yeah.
about that? Thank you. I apologize. So on the first subject we did in this, Mark and I were in the lab at the time, and it's a trained cyclist. And immediately after the exercise, we have to get them to a chair to stimulate them to test for fatigue. Couldn't get up.
That's not the epidural, that's the fatigue.
Oh, heavens, yes, that's the intrathecal fentanyl.
Okay,
Yeah, well, not quite against that. So then, and that happened in every subject. Marcus is a very big guy. He could lift these guys up and bring them back. We were impressed with that. So then, in Utah, he did a study with muscle biopsies. And he saw with that, what that excessive fatigue took with it, because it's big, it's like 30 to 40% greater fatigue. So he saw the use of the phosphocreatine, lactate, so it has those consequences. Now, does it damage the muscle personally? I don't know. I'm not a muscle guy, and I'm not going to go to find out, but thank you for asking that. I think that's pretty significant.
yeah, I know the paper you're talking about, the metabolites get driven higher or lower depending what it is.
Yeah.
But there's no sign, I guess, in that study that is causing muscle damage per se. It's just
So,
limiting.
I don't think so. Suppose though, given the effect on metabolites and given the transient effect on the ability to ambulate, that was there for quite a while, by the way, afterwards. I wonder if that's repeated all the time with the muscle effort inhibition. I don't know.
Yeah.
I don't know. And we're not gonna certainly permanently block those people if I know. But that is an excellent question. Yeah.
You kind of build on that comment. Is it clear, so the brain has their critical set point that it won't let us get past for fatigue. Is it clear how much of a buffer it gives us? Kind of how much could we go beyond that and still be able to emulate without getting some of those transient negative effects? Not true.
But the degree of fatigue was, as I said, 30 to 40% increase without this inhibitory effort feedback. That's a lot. That's a lot. I'm still impressed by that guy that couldn't get up. I was kind of mad at him, saying, come on, we have to test your, that kind of impressed me. There was Brenda Bigland Ritchie in the early 80s, if I recall, that suggested this. There's gotta be a break on this or you're gonna damage muscle. I can't claim that, but I've given you the evidence for the effect seems to be. Big effect on performance. The effect on performance is substantial. Inhibiting performance. That break. And if you want to really perform well, forget about what it's going to do to your muscles. For that moment in time, if you can inhibit those, you're going to do well. And things like in the pathophysiologic side, the data out of Laval University from Francois Montet a few years ago He's the only one that blocked them in COPD. COPD patients are severely exercise limited, both by their lungs, certainly, because their dyspnea is substantial, but they have terrible aerobic capacity of the muscles. The biopsy from taken Francois did a lot of the basic work on that. And when we do, I can't remember the wattage now, but it was about equivalent to this, 4-6 minutes, you see fatigue. And of course, our age match controls, there's no way, it's not even close, so they're highly fatigued. Well, he blocked the afferents from them. They doubled their exercise time. Now, a lot of that was because the breathing frequency fell substantially and the dyspnea got less. But he actually did do that in a group and tested for the fatigue as well. Greatly increased the amount of fatigue in them. So, yeah, it seems to be upregulated. And I don't, it's in, for those interested in the neurophysiology of feedback and stuff, we don't know whether these receptors are actually sensitized. That's a little bit of work's been done on that. The reason that they become more important in their contributing during exercise could be just because the stimuli are excessive. They accumulate more metabolites, for example, or both, sensitization plus greater stimulus.
Other questions from the audience? Walter?
Yeah,
Ask a couple of questions from a non-physiologist. You mentioned fatigue a lot. How do you quantify fatigue? How do you do that?
right. We stimulate the motor nerve super maximally and measure the force over. That's to take the brain out of it. So motivation is taken out of it. So that's the test for muscle fatigue. It's classic one. You can also simulate at different frequencies and do what is called force frequency curves to test it. But it's this type of fatigue that, and you can do the same thing for the diaphragm. You simulate the phrenic nerves. Here, super maximum. You need to get it up, make sure you've got it fully engaged and measure the pressure difference across the diaphragm. And these kinds of fatigues are labeled low frequency fatigue, and they last for a couple of hours following the exercise. Is that okay?
No, that makes sense. And we have done some work where we do what we call, superimposed twitch technique, where we stimulate the femoral nerve and so on. But usually we just give 2 or 3 pulses. And the one thing that we saw is when you have people exert a certain amount of torque on a Cybex machine, if you do that superimposed twitch, you get very, very variable results.
Oh, yeah.
And
Yeah.
so how do you,
We do it at all kinds of different frequencies.
and also like long pulses?
Oh, yeah, why not? But that's a major problem with it. I agree. Good for you. Yeah. My favorite one for the phrenic nerve was 10 hertz. You got such a huge pressure difference when you did that, and tetanus.
So 10 hertz will cause a tetanus.
Yes,
In
yes,
the,
yeah. And a big change. So if you're looking for change, you definitely have a good marker.
the other question.
It hurts, unfortunately.
Yeah, I have a good story there.
All right.
I have a good story, because when we did superimposed twitch techniques, we did that with people who had osteoarthritis, elderly people, 70, 75-year-old men and women, nobody complained. We did it with other people, nobody complained. And then we had a group of people in, they absolutely complained and were whining and so on. Who was that? The Calgary Flames. Hockey players. They couldn't stand it.
Well, did you keep doing it? That wasn't very nice. You kept doing those work.
Why, you use mostly cycling as
Yeah.
a model.
Yeah.
And I always think of cycling as, when people get fatigue, it's more a muscular local fatigue. It's not really necessarily a cardiovascular, heart pumping type of a limiting factor.
I think there's probably I'm not an expert on that, but probably the locomotor muscle specifically involved. But believe me, You measure oxygen consumption. You can put a trained cyclist now, like these guys. You can go up to the point where the workload keeps increasing, but the VO2 levels off. That's cardiorespiratory limitation. That's aerobic capacity. So that's a good test of any means of exercise when you're there now. A.V. Hill told us that in 1920s. You need to go where you get that plateauing of the VO2.
You told us many other.
Yeah,
things.
we've used treadmill exercise too, especially for the fatigue studies. And I think, yeah, slightly different ways of fatigue, but any means of doing to get rhythmic exercise, I think gives you the answer.
So you were also talking about work of the breathing muscles.
Respiratory muscle.
Yeah, exactly. How do you quantify that? How?
We put we want to measure intrathoracic pressure. So we put down a catheter into the lower esophagus. So hold it, hold. Oh, I got it.
Demonstrating on me.
I'm sorry, I can't find it, but it's a very thin floppy, like a noodle. Put it in there and measure pressure. And it's been shown a long time ago that's equivalent to intrapleural pressure. And so that's how we measure the work of breathing. Measure the work of the diaphragm by having two of them. One in the lower esophagus, one in the stomach. And we measure the force over pressure across the diaphragm. That's how we measure
If
work.
I cycle a maximum effort for 30 minutes, how much work would I perform with my breathing muscles compared to my cycling muscles? And how much would you unload the system by taking the breathing muscles out?
Okay, if you do that, we've measured that in untrained people whose maximum ventilation is about 90 to 110 liters a minute, adult, that the oxygen cost of their breathing is 8 to 10% of the total. In a highly trained athlete whose maximum ventilation is above 150, 180 liters a minute, they're up around 15 to 20%. And it's probably that we don't know this for a fact. It's probably, well, actually, in an animal, it's probably the same thing with blood flow. Of the total cardiac output, about 15% would be going to the respiratory muscles. Is that okay?
Yeah.
It's a lot more than we thought.
Have you ever looked at this whole idea of?
But it's not just, remember, it's not just the diaphragm. When you're exercising your maximal, it's been estimated from EMTs, you're probably using between 40 and 45 muscles to breathe. Both as dynamically to shorten the muscles plus fixators, to fixate the trunk, upper back. Yep. So it's, it involves a lot of muscle. The sternocleidomastoid follow showed us beautifully with EMTs here. And that didn't exercise real heavy before he started coming. Yeah. So it's a lot of muscle mass to take a breath when you're exercising hard. Well, I hope you remember some of these neurofeedback mechanisms. In addition to the feed forward one, in addition to so-called voluntary activation, they play a role. And I think they're pretty significant. Classic kind of neurofeedback receptors. And in the clinical side, it's becoming a big deal. People are really trying to find a way to silence the tonic activity on the bodies. The only way to decrease the contributions from, say, local core muscles to make them fitter. That's good. Oh, that's interesting. Activity, not just in animals now, but also in people. One way to decrease the tonic activity of cardiovascular is physical training. Prolonged physical training in a rodent, not in a healthy animal. Can't seem to change that with exercise. They stay the same. But in heart failure and in hypertensive animal models, when they train them over time, see a big decrement in carotid receptor sensitivity. I think the reason is you're increasing blood flow. And shear stress in this region makes the difference. Yeah, that's the first, there's even in the textbooks, they say that highly trained athletes have desensitized carotid bodies. That's not true. That's a way overgeneralization. People think that in exercise training in a healthy personal gym. No evidence for that. But in diseased people with highly sensitized chemoreceptors, it seems to have a difference. And that's great, eh? Convince people to exercise, one more reason for this with the hip movement.
Any last questions for Dr. Dempsey? Don't see any hands going up, so let's thank him for his talk.